Welcome to Porchlight, a presentation of Porchlight VNA and Home Care, formerly Lee Regional VNA, providing first-rate personalized care for thousands of people in Berkshire County and in the hill towns of Hampden and Hampshire counties, all in the comfort of their own home. And speaking of comfort and feeling good and healthy, you know, baby boomers today more than ever are so much more active, but however, their bodies tend to break down a little bit. And I'm very happy to welcome to the program someone who knows quite a bit about this from the work that he does. He's an orthopedic surgeon. His name is Laurence Cohen from Berkshire Orthopaedic Associates. So Dr. Cohen, welcome to the program.
Thanks, good to be here.
And I love talking about this particular topic because now more than ever, people have options to stay active through their years of their 60s and 70s, and you're an active guy yourself, and people will be surprised how old actually you are, and how active. But I think today they have a lot of options.
Well, there are a lot of options from an orthopedic perspective. Now, if you're fortunate enough to have your body in good enough shape that your limitations are with your joints, and that's not unusual, then you can remain active. And we've got a number of non-operative and operative measures that will keep joints working, and patients that formerly had to assume a relatively sedentary life in the past because of natural aging and deterioration of joints now can continue, assuming again, if that's their only limitation, they can continue an extremely active lifestyle. And that's what's new in the last 30, 40 years. Yes.
Yeah. And especially in the last perhaps even decade with some of the new technologies that people have, and often, you know, knees are the kinds of joints that tend to break down, you know, hips, these types of things, and now having knee replacements that are a lot more sophisticated perhaps than they were decades ago.
Well, I have a unique advantage. I'm 71, and I started my orthopedics in 1969, so I can tell you that with absolute certainty that those were the very first years that we were putting in knee replacements, artificial knees. We had just been putting in hip replacements in the sense that we know them now for about 4 or 5 years at that point. So they were still very new. So before, let's say, 65, 66, very few people had artificial joints in them. We did crude joints. I mean, frankly, it's frightening. The old days, you could get a guy, and I knew a number of these wonderful old surgeons. They'd come up with an idea in their garage and say, you know, this looks like a hip. They put it out there, FDA. If it existed, it didn't seem to care. And then we'd start putting those things in, and whoops, this didn't work. And now it's a lot different. So, God, yes, the joints we put in are very. They've been tried, they're tested, and the materials have only improved, and they last a lot longer. So we didn't even know how long they'd last when we were first putting them in. We only put them in people in their mid-80s, perhaps, because we weren't certain of how long they'd last. Now, I think we can honestly say that we'd like to think that a knee or a hip ideally will last 20, 25 years before it shows signs of wear.
And so, you know, being able to have that good technology, it seems as though that people, rather than having to find different alternatives dealing with the pain, this seems to be more of an option. But there's a choice there. There's still a decision that leads up to this. You know, surgery, no matter how easier it is, it's still a difficult decision to make, and takes a lot of research and so forth. So what are some of those thresholds, perhaps, that people need to look at as to I may or may not be appropriate for surgery?
Well, presumably, you know, we have two issues here. We have the patient's desire for something definitive, and we have the doctor's threshold. And if you have a reasonable doctor, surgery is a last resort. And when all other measures have not helped, and let me digress and tell you that I tell every patient, anyone listening to this knows that I say that you never have to have an artificial joint. And particularly, I'm speaking mostly about knees and hips. You never have to have one. You just live with it. If you can't live with it, then you pick your mode of activity that you can live with. But so the decision is really the patient's. If the doctor says you have to have it, I'd leave that doctor, because that's not honest. You don't have to. And then, if the doctor feels you're not bad enough for it, well, that's another issue. And then you find another doctor. You probably could always find a doctor whose threshold is low enough for you, but that's not good medicine. All right, so now, the most important thing, that I have my own guideline, personally, just mine. One of my guidelines is if someone has pain at rest, you lie down, the pain doesn't go away. Gee, that's a patient that definitely should have a joint replacement if they want one, and they have pain even when they're resting. I don't hold back. That's presuming they have X-ray changes that suggest that they're a candidate for a joint replacement. So that's my biggest. And then the other thing I tell patients is if they're otherwise well, they don't have need for oxygen or to get through the day, or otherwise could be active, and their heart permits, and they're postponing or canceling plans on a vacation or some active activity that they could do with their family, and they're doing it because I can't do it because my knee prevents me from taking that trip or that traveling to Europe, whatever. Then that's, if you're otherwise well and you want to do these things and this is what's holding you back, another reason to change, because there's no reason to be held back by inability to walk because of arthritis.
And looking at that, of course, there are people who also want to go out and play tennis and be able to do all these things and do the things that you do. I know you're a big bicyclist, so their threshold may even be sooner because they're not able to do those types of things.
I honestly think that the majority of the knee replacements I do are on men, or so they can play golf, and some women, but far more men. They want to continue to play golf. Some play tennis, but we do discourage impact sports. We do discourage running. We discourage skiing. Now, we know that there are countless people out there doing these things with artificial hips and knees. And I did hear a paper presented once of the number of people doing the Boston Marathon who have artificial knees and hips. But we discourage it because we feel that it could reduce the length of time you can anticipate that joint will live. And that means it wears or loosens or something like that.
Now, one of the elements there, because when you hear about those impact sports, it's kind of this, the message is a little mixed in the sense that those impact sports actually do help to strengthen the bone to make them healthier. But in the case of a knee replacement, you're saying that that sort of impact is not the right way to go post knee surgery.
Now, I believe that the activity that will help sustain bone strength, particularly in the osteoporosis patient, for example, walking will provide that same. That's low impact. Will give you that same benefit so that your bones aren't weakening. Any weight bearing, it's the impact. And why do we say that? Because we fear that this component is metal and it's anchored to your bone with bone cement, and then in the case of the hip, we rarely use bone cement in a first hip replacement, and it's that interface between the metal and the bone, or the cement and the bone, that can loosen with jarring. So this is what we're concerned about. And then on top of that, there's a plastic, polyethylene, which is interposed between these two sides of the joint, and that polyethylene can wear, and presumably the impact will help it wear faster.
And of course, perhaps another surgery, the arthroscopic variety, provides a sort of less invasive, I guess would be the best way to describe it.
But arthroscopic surgery is only for the patient. This is before you get to total joint replacements, right? And not a cure-all. As a matter of fact, arthroscopy for arthritis is very questionable, and it's very controversial. There was even a threat at one point that Medicare was not going to permit it. They weren't going to fund a physician doing arthroscopic surgery for arthritis based on a study done on veterans that were through the VA hospital, where they looked at patients that had arthroscopy for knee arthritis, and half the patients, they made little holes in their knees and did nothing, and the other half, they actually did something, and the two groups, they looked at them after an interval, were the same.
Interesting,
Yeah.
interesting. And so part of it is the preparation of it as well. So there's opportunities for people perhaps to do what they describe as prehab before a surgery, to be able to make sure that you're prepared for that, for when you have the surgery, and then you need to do rehab afterwards. So talk to me about that and what you recommend for that kind of thing if someone has chosen to go through that, and what that means for them.
Well, when you're not using a joint fully and normally, the muscles around the joint, and all joints are surrounded by muscles, they're going to weaken. Just relative disuse will cause those muscles to weaken. So it's not logical at first for someone to want to be vigorous on a joint that hurts so much. So part of that prehab is to encourage them that in spite of their pain, not only will they not harm themselves, perhaps they'll hurt, but they won't harm themselves, to strengthen those muscles that surround the joint, so that when they get into the post-operative phase, which starts on day 1 after surgery, that their muscles will be in the optimal condition, from which they're going to be, hopefully, will build up even more.
And then having those great rehab services, Porchlight provides rehab services in the home. I mean, are you seeing more of that rehab within the home environment because of convenience for people, and also a way to acclimate back to their home environment more effectively?
It's more than convenient. We know, as all patients fear that they're going to get thrown out of the hospital the next day, practically, that they simply are not going to get enough in the hospital. There are many patients are home 2-3 days after surgery, and that physical therapy really has to be provided at home, and VNA services are fortunately there to fill that void. And so
it's interesting because you
essential.
say in the hospital, because the way the reimbursement structure is now, and in healthcare, people know this very well, but the way that Medicare works is that you're there for 3 days, and then
3-4 days you're out,
and then you're out, and there's a emphasis to do that from a bottom line standpoint, from the financial standpoint for the system. So therefore, having that rehab, it is incredibly important, because it hurts having a knee surgery and then getting back on your feet. It doesn't happen in a day.
I will absolutely, and I sometimes I'm in meetings and doctors brag how quickly they get their patients out. But I'll tell you the little dirty secret that sometimes these doctors that have these great statistics that they give the patients an anesthetic will last just enough time for them to get the patient home, and then poor VNA has to deal with the patient in pain. Yeah.
God bless the VNA, our friends at Porchlight, and those folks really do a great job, because it's a hands-on. And I know you've experienced it, maybe not firsthand getting it, but seeing someone go through physical therapy after a knee surgery it can be actually excruciating to watch, because the pain that you have to go through. Now, I don't want to scare anyone about that. I mean, it is temporary, and it's strengthening the joint and the muscles around it. But to get those legs straightened again and getting the angles, it's pretty important stuff.
The good news is that they may not be newer prostheses, but we do have newer techniques we're trying to find to minimize that initial post-operative pain. And they're regional blocks where just the knee area can be anesthetized. Those are things we're trying to find a standard for. There are about 10 different ways to to try that, and none of them are 100% effective, but some of them consist of actually, at the time of surgery, just before you close the incision, you inject some long-acting anesthetics and we're looking for longer acting. Some of the best long-acting ones won't last more than a day. Some of those blocks, they have a little tube that goes through the skin, and a little air pump that just like a balloon, and that balloon gets expanded, and then it squeezes the medicine over the next 2-3 days.
Which
Just to that
certainly
area.
necessitates, again, further oversight,
Yeah,
because the nursing aspect and having an RN coming into the home and that sort of thing, very important, because you don't want, especially a patient who's already immobile as it is, and vulnerable because of what the surgery does. So that's a good point.
Yeah, they need supervision. Someone has to come and make sure that little tube is working, is not clogged, that the tube hasn't pulled out. These are essentials. You can't leave a patient unattended and just send them home, as one thinks we do.
And you do your surgeries, I believe, in Great Barrington.
I do.
You do, and because you have a whole the Associates has an office in Pittsfield, and also the satellite office. Do we call it that in Great Barrington?
It's a satellite office. I'm there. I'm the only one there much of the time, and 3 of the guys from Pittsfield come down for a half day. 3 days a week, but I'm there more than the others. But yes, my associates, they do the majority of their all of their joint replacements in Pittsfield.
And so to be that guy in Great Barrington doing work, I think that's a wonderful thing, to still, because it is a unique community. I mean, there's no one who would suggest that Great Barrington and southern Berkshire County is not unique. It certainly is. So. To have orthopedic surgeon doing actual surgeries in Great Barrington, there's something to be said for that.
Yeah, they've always had 1 or 2 orthopedists over the years, and it's a rather small hospital, as you know, but there is a place. But there really isn't a place for, needless to say, the major trauma, auto accidents. They go directly to Berkshire.
Right, or even Bay State, ultimately.
And then I should add that there are patients who have heart conditions or lung conditions or both that can undergo surgery with a little bit of a risk that will not be taken at Fairview. And those patients are classified as 1 through 4, and a certain, I think it's class 4, no surgery is done on those patients at Fairview, whereas done commonly at Berkshire, even electively, Berkshire Medical. It has to do with the intensive care unit, the size, the availability of several specialists at all times, et cetera.
And you also have a different specialty as well on the wound care. And I know it's not a big thing that you love to advertise, but who loves to talk about wound care? However, it's a very important service, and another one of those where people within the home having VNA services available. That's an important cohesion that's there.
Wound care, in the true sense, doesn't necessarily refer to the average normal wound that surgeons make, that they close. That's certainly the wound I know most commonly. Wounds in wound care centers are usually ulcers that form in diabetic patients, patients that have poor circulation, or both. And those are patients for whom there is now a home, so to speak, whereas before, primary care doctors would handle it, some general surgeons will handle them, and not necessarily well, because they're difficult to treat. Each of these wounds is a little different and requires a little specialty, and in the last 10 years or so, this has become quite a specialty. And there's always been the need, but there was never a facility, and these facilities there are quite a few in the country now, and it's pretty good advance, because any doctor that encounters a patient with a wound now feels comfortable just saying, I just go to the wound center. And even with the occasional surgeon, thank goodness I don't have any that I've sent myself, except once in a blue moon. They have a problem with a patient on whom they've operated, and then they have a wound problem, and then they'll just send it to the wound center because they know that they can get that wound healed up faster with someone who has more time for those patients. Sometimes they're more time consuming, and have several different treatment regimens in their armamentarium, which is what you'll find at the wound center. In the past, all I knew was it's a clean dressing and change it. Now we've got these very special dressings for different applications.
And that's a great resource to have, also in southern Berkshire County.
Absolutely.
To have that.
But understand that all wound centers in this country are centered around hyperbaric oxygen. And not every, actually a small percentage of the wound patients are receiving hyperbaric oxygen, but that's one of the modalities that can be offered for a certain subset. And that's there too, and that's really what makes it unique.
And and certainly you're a student of your art, and we've talked about from the 1960s and moving through the sort of evolution of things. You know, orthopedic surgery, where do you see it headed? You know, are there other breakthroughs on the horizon, or have we gotten to a place where basically it's become very, I mean, your practice does a lot of surgeries. Sometimes surgeons like you will do 2 or 3 or more surgeries per day, and it has become very much systematic and routine, dare I say it, although no surgery is routine. But what do you see in the future?
I think every advancement in all surgical fields, be it general surgery, urology, all the changes have to do with minimally invasive. Some things simply cannot be safely done with a minimally invasive approach, but more and more, if something new is out there, it's going to be in the form of less of an incision, more things done from outside the skin, and using the image intensifier, or my generation would call it fluoroscopy. It's X-ray in the operating room guiding you, and you manipulating and changing things from the outside and watching it on an X-ray, and then doing what has to be done through a minimal approach, just the least amount of an opening through the skin. And that's, in a nutshell, what's new. And new things. I mean, in children's surgery, a lot of it's done now through small holes when you want to stop something from growing or change the direction it's growing. That can be done using an image intensifier through small holes. Yes.
Interesting. And so while those may not be comprehensive surgeries, perhaps, like as you suggested, kind of like a cortisone shot, it can kind of, reduce the pain and reduce some of the issues, for the short term, holding off the ultimate surgery, which would be sort of a replacement method, which you still can't, like you said, you can't replace that as a...
Well, actually, it's gone both ways. There was a move afoot that was minimally invasive knee replacement. I think that's very few doctors do that. It's causing more problems than help. But we have ways now to get back to it in a little different system. The minimally invasive knee surgery, I don't do it yet. Minimally invasive hip surgery, it's being done at Berkshire now. A different approach, has its risks and benefits.
And is it the incision goes in from a different location, or how does that work?
The incision is made from a different direction, and it's made much smaller. And the end result is the same as the old-fashioned way, but it's a smaller incision, different approach. It allows it to be done more easily for the patient, perhaps not more easily for the doctor. And it's an alternative. It's not necessarily better. The patient has to help make the decision. As to quote an article I read in the New York Times about just this, it said, you pick the doctor that you're comfortable with, and then you do it the way that doctor wants to do it. And that was the advice after a rather controversial article in this past March about minimally invasive surgery, and I like that.
Well, Dr. Laurence Cohen, we're fresh out of time. We could probably have an hour show with you quite easily, but Dr. Cohen from Berkshire Orthopaedic Associates, how can people get in touch with you and have further consultation?
We're the only orthopedists in Berkshire, at least, no, I shouldn't say that. We have our friends up in North Adams. Berkshire Orthopaedic Associates. Yeah, we're
so
easy
Google
to
you.
find. Yeah. But you got to spell, if you go online on your own, you got to spell pedic the old Greek way, P-A-E-D. It means straight child, not straight feet, P-E-D, so P-A-E-D.
There you go.
Yeah.
So we have BerkshireOrthopaedics.com, I believe.
Yeah,
So Dr. Cohen, a great pleasure. Thank you very much.
Good to be here again.
And this has been Porchlight, a presentation of Porchlight VNA. Thanks for watching.